and sponsored by Dr. P. Alikutti's Kottakkal Ayurveda Pharmacy. Dr. P. Alikutti's Ayurveda Pharmacy is Alikutti's Kottakkal Ayurveda and Modern Hospital since 1965. And KAP manufacture around 400 classical products and 40 proprietary medicine in their own GMP and ISO certified production unit. They also developed Asian formulation into proprietary medicine after a series of tests and research studies conducted in their R&D lab. For further information, you can contact Dr. Jasu. And on behalf of Ayurveda Map, I welcome you all. And Ayurveda Map was a new venture. It started by a group of young doctors in the year 2016. And it is officially PM Varyasa in the year 2017. And first of all, we are started as an in-hand practical session. And these all are our in-hand practical sessions. And due to these pandemic situations, COVID, online, and
Dr.
these
Anjana,
all are our online sessions.
Your voice is breaking. You can off the video and speak. Okay.
Yeah, these all are our online sessions. Doctor, am I audible now?
Yes, you can continue.
Yes. And these all are our online sessions. And the Swadhyaya, the new venture to support the students academically during the pandemics, and we will provide the recorded classes, detailed notes, and one-to-one doubt clearance sessions, etc. And we bus also our online session for cosmetic preparations. And we also started a one-year postgraduate diploma in Ayurveda cosmetology. And our upcoming sessions are Dekha, on OP level disease management in Ayurveda. And it will be started on March 28 to April 21. And the registration is ongoing. Those who are interested, they can contact Dr. Jasul. And today, Anubhava free webinar series. And the topic is diagnosis and management of peripheral neuropathy. And it will be taken by Dr. Mirdaz K, Director and Chief Physician, Ethini Ayurveda Hospital, Calicut. So I wholeheartedly welcome Dr. Mirdaz to today's session. Welcome, sir.
Okay, thank you. Can I share?
Yeah, doctor, you can share.
Is the PPT visible for you?
Yeah, it's visible. So you can start now.
Okay, thank you, Dr. Jasul, for inviting me for this session. And today we are going to discuss about the peripheral neuropathy. As we know, in peripheral neuropathy, it is very important to localize the site of nerve lesion and the pattern of distributions of nerves. So a careful history and examination with a thorough understanding of the anatomy of the peripheral nervous system is essential. And additionally, we need NCV and EMG studies which can further localize the lesions and helps in understanding the pathophysiology. As far as Ayurvedic treatment is concerned, pathophysiological evaluation and electrophysiological studies are more important because the treatment modalities can be changed according to the pathophysiological changes and some precaution may be taken based on these findings. For example, in neuropathy, if you are able to identify the neuropathy as axonal or demyelinating. So based on this axonal neuropathy or demyelinating neuropathy, the types of doshas involved and the as it is a Vada Vyadhi, the types of avarana involved, etc., can be inferred by these electrophysiological studies. By this, the treatment and the drugs can be selected based on these findings. Because while we are doing Ayurvedic treatments, like Swedana procedure, especially in peripheral neuropathies, especially in demyelinating neuropathy, which is autoimmune or immune-mediated demyelinating neuropathies. For example, I am giving you an example. If you are doing Swedana procedures, or when we are doing some heat applications, in this type of demyelinating polyneuropathy cases, or for example, Guillain-Barré syndrome, or for example, multiple sclerosis, the symptoms of the patient is found to be aggravated by these procedures. So it is very common, and it is very common mistakes that we are following doing Swedana procedures. Thereby, the patient is getting aggravation of that symptoms. So it is giving bad images or negative feedback from the patients as part of the Ayurvedic treatment. So several cases has reported like this. And this phenomenon in modern, we call it as Otto phenomenon, where in demyelinating neuropathies or demyelinating pathologies, the patient may experience heat intolerance, especially heat applications, hot atmosphere, and some internal the factors which will cause increase in body temperature like fever. In these cases, the patient will experience aggravation of the symptoms due to this heat intolerance or due to loss of withstanding or lack of withstanding this heat. So this is very important for us because in Ayurvedic procedures, as it is a Vada Vyadhi, the Sneha Swedana is very important treatment. So every person or as a doctor, everyone doing this Swedana procedures in many cases, but be careful when we are doing Swedana procedures, especially this type of demyelinating disorders. So this is an introduction because this is the importance of identifying the pathological mechanisms behind the disease, especially neuropathies. We have to identify the exact mechanism by pathophysiology and by electrophysiological study. Thereby, we can modify the treatment or we can and then adjust the medicines based on these findings. For example, in Vada Vyadhi, we know in peripheral neuropathy or neuropathies or the CNS lesions, whatever may be, it's coming under the category of Vada Vyadhi. So we know Vada Vyadhi, the pathophysiological aspect of the or samprapti of Vada Vyadhi based on two factors, Dhadukshaya and Avarana. So the most difficult part of this concept is even sometimes the Avarana features, the Avarana clinical features may not be evident in the patient. That is very important finding. The patient may present you with all the symptoms of Vada Prakopa Lakshanas, which may mimic the Dhadukshaya or Vada Prakopa Lakshanas. The Lakshanas of other doshas are not evident by the clinical examination. And we have a method in Ayurveda, we are doing Upashya and Anubhashya techniques, thereby we can identify the other doshas involved. But advancement in modern investigations and diagnostic methods, it is very easy or it is helpful to identify the involvement of Avaraga doshas, especially in Vada Vyadhi, by analyzing these electrophysiological and investigative methods, blood tests, whatever may be. So it is very important to know that. That is why I am giving this example like Utto phenomenon in demyelinating neuropathies, contraindication of some Swedana procedures as an introduction to know the importance of all the aspects of pathophysiological aspects of what happened?
Sir, please raise your voice.
want to wait. Okay. Am I clear now?
Yeah.
Okay. So up to this point, you're okay?
Yes, sir, you can continue.
Yeah, okay. As I told you, this is very important to know the exact mechanism or pathophysiological or mechanism or pathological mechanisms behind the nerve damage or whatever may be the reason that we have to identify, and we have treatment options and modalities accordingly. That is very important. So we will change our concepts from the conservative methods to a new level or a special level. That is very important. So from beginning itself, we are dealing with the diagnostic aspects of the peripheral neuropathy, where based on symptoms, if the symptoms come to the patients, if the patient is come to the certain signs and symptoms, especially if the fibers involved, the types of fibers involved is important. We have to know what type of fiber is involved. So where the motor fiber, if the motor fibers are involved, the patient will experience weakness and some muscle twitching like fasciculations or muscle atrophy, wasting is evident. And if the sensory fibers are involved, the patient may experience positive symptoms and negative symptoms. Example for negative symptom is numbness, loss of sensation, reduced sensation, etc. And the positive symptoms includes tingling sensation and altered perception of pain and touch, etc., etc. And if the large fibers, that's in the sensory fibers, if the large fibers are involved, the patient will experience ataxia, imbalance, and reduced vibration and proprioceptive sensation. At that time,
excuse me, doctor.
yeah.
Yes, can you pull the laptop to your front so much so that we can hear you more?
Clear, Allah?
Okay, okay. Yes, you can clear. You can continue.
Okay.
Okay.
Okay, now it's clear.
Yes, yes.
Yeah, okay. So when there is large fibers are involved, there will be ataxia or sensory ataxia or imbalance will be there, and there will be reduced vibration and proprioceptive. So the patient will give you imbalance while walking, especially in the darkness, especially towards the evening. The patient will give you that history of loss of imbalance. That is due to the vibration or proprioceptive JPS, joint position sense is lost there. That is why it is like this. And if the smaller fibers are involved, there will be decreased pinprick and temperature. Means there will be affection of the pain and temperature. So the patient will experience the more pain and temperature related issues. And if there is autonomic involvement, autonomic nervous system is involved, there will be altered sweating, orthostasis, and constipation, and sometimes urinary retention or palpitations may be seen in patients. So urinary retention is very common, especially in diabetic neuropathies, if there is autonomic involvement, and orthostatic hypotension is also very common findings in some patients with the neuropathies, especially in diabetes. So these are the, based on the symptoms, we are able to identify the types of fibers involved, where we can focus the treatment based on this. Okay, that we will discuss further. So these are the diagnostic based on the symptoms. The next level is the pattern of involvement of the nerves. The first one is there is a symmetrical length dependent distal weakness with the sensory loss. Generally we call it as generalized symmetrical polyneuropathy. So where we are focusing which nerve is involved, or types of how many nerves are involved. We can that there is mononeuropathy, there is polyneuropathy. So here we are going, when a patient comes to you with distally involved, the more distally involved polyneuropathy, generalized symmetric neuropathy, the clue to the diagnosis goes like this. It may be there is a chance for this type of types of polyneuropathy is seen in metabolic neuropathies, example diabetes, and in some toxic neuropathies like some lead toxicity or alcohol toxicity or some drug toxicity. So in toxic neuropathies, and in some hereditary conditions like Charcot-Marie tooth disease that we will discuss further. And even if the patient is, so the first session, first level, the symmetrical polyneuropathy is there, but it is predominantly distal predominant, or involvement is distal predominant, where we will get a pattern of glove and stocking types of neuropathy, glove and stocking types, where distal foot and distal hands are in, foot and hands are involved more. So that we call it as, and it is glove and stocking type of neuropathy, where we should suspect some metabolic neuropathies or some toxic neuropathies. And sometimes the patients comes to you with the polyneuropathy, but there will be involvement of the distal and proximal muscles. And it may start with the distally and as early as ascending to the proximal level. So there will be distal and proximal sensory loss and weakness, and may be associated with areflexia. In this type of cases, our clue to the diagnosis, it is type of inflammatory demyelinating polyneuropathies, especially Guillain-Barré syndrome and chronic inflammatory demyelinating polyneuropathy. So based on this finding itself, there is a clue to the diagnosis. If the patient is purely distal, there is a chance to get the metabolic neuropathy or type. If the patient is presenting with the distal and proximal weakness and with the sensory issues, it indicates inflammatory demyelinating polyneuropathy. And when a patient, there will be mononeuropathies in different parts of the body. There will be neuropathy like mononeuropathy, but more than, it's not generalized, it's not symmetrical. It is called multiple mononeuropathies or mononeuritis multiplex. Sometimes it is called mononeuritis multiplex, where different nerves are involved, 1 or 2 or 3 nerves are involved in different region of the body, especially cranial nerves, or especially upper limb, or especially lower limb, like this. If the patient comes to you with this type of neuropathy, multiple mononeuropathy, it is called, the main reason for that type of it is vasculitis or vasculitis induced neuropathy. And sometimes the patient will come to the asymmetric weakness with the intact sensory system exam, or there will not be any sensory findings, but the motor system is involved more, or motor nerves are involved more. If the patient comes to you like this, we have to clue about the motor neuron disease, and also the multifocal motor neuropathy is the disorder there. So we have to suspect if there is no sensory involvement at all, and there is no findings, and only motor neurons are involved by the examination or by the electrophysiological studies, it will give clue to the motor neuron disease or multifocal motor neuropathies. And if there is significant autonomic involvement, autonomic nervous system, as we discussed last slide, if there is palpitation, if there is orthostatic hypotension, if there is altered sweating pattern, and if like this, if there is autonomic involvement, we have to, the most common autonomic involvement is in diabetic neuropathy, and in some cases of amyloidosis, the deposition of amyloid protein. So in diabetic neuropathy, it is very common, autonomic disturbance is very common. And based on another level diagnostic aspect is this is very important for us also, as we have discussed in our in introductory session, differentiating demyelinating and or axonal. In modern concept, there is no much difference, but in Ayurvedic treatment aspects and Ayurvedic treatment modalities, we have to focus, we have to differentiate whether the neuropathy is demyelinating or axonal. For example, axonal neuropathies are very common in trauma, toxic neuropathies, ischemic, like ischemic neuropathies, ischemia to the vasa nervorum, and metabolic or some genetic conditions. Demyelination is very common in compressive neuropathies and some hereditary neuropathies, and it is very, very common in acquired immune-mediated neuropathies like GBS and Guillain-Barré syndrome and chronic inflammatory demyelinating polyneuropathy. So this is very important. We have to differentiate the type of pathophysiology based on the demyelinating or axonal, where we have more, we have to change the, or we have to modify the treatment accordingly based on these findings. So based on pathophysiology, the diagnosis goes like this, whether it may be demyelinating or axonal. And we are entering to some examples for the mononeuropathy or polyneuropathies, etc. So mononeuropathy where single nerve is involved. And it is very common in our clinical practice. We call it as entrapment neuropathies. Entrapment neuropathies. In entrapment neuropathies, there are different terms are used based on the compression and based on the nerves involved. The very common the condition is carpal tunnel syndrome, where median nerve is involved in the carpal tunnel of the wrist. So the wrist is involved there, and the tardy ulnar palsy. For ulnar palsy, we call it as where ulnar nerve is involved. It is in the cubital tunnel or cubital fossa, elbow. And another one is Saturday night palsy, where it's a spiral groove in the arm where the compression is happening, and the radial nerve is involved, and the patient may present you with the wrist drop. And peroneal neuropathy, where common peroneal nerve is involved, it's maybe compressed at the fibular head, and especially in some posture of the lotus posture of the legs. And tarsal tunnel syndrome, it's very rare, but it may be presented to you, and it may be misdiagnosed with some other diseases. Tarsal tunnel syndrome, where tibial nerve is involved, and the angle is the angle where the compression is happening at the angle. So site of lesion and the nerve and the name we have discussed here, and the treatment aspect and treatment approach we will discuss further. So these are the examples for the mononeuropathy, where one nerve is involved, and the very common mononeuropathies include entrapment neuropathies or compression neuropathies, where nerve is compressing under a structure. We will name the disease accordingly based on the nerve and the site involved. So like for example, carpal tunnel syndrome, tardy ulnar nerve palsy, etc. Okay, am I audible now?
Yeah, doctor.
Okay, so when a patient comes to you with this type of mononeuropathy, for example, the patient comes to you with a very common finding, it is that is carpal tunnel syndrome, and maybe sometimes the patient comes to you with the ulnar nerve palsy and a Saturday night palsy. Especially it is called Saturday night palsy because after a heavy alcohol intake, the patient will experience while awakening in the morning, the patient will experience. So these type of cases are very common to the OPDs, and it can be treated well. That is very good. So we have to know the exact mechanism and exact causes behind the. So when a patient comes to you with a mononeuropathy, it is very important to know the what is the reason behind it, or the causes or the causative mechanism. And the main common cause is RSI. We call it as repetitive stress injury. That is occupation, especially in the person software engineers or IT professionals. They are experiencing this type of carpal tunnel and cubital tunnel or cubital fossa syndrome. These occupations that undergo repetitive flexion contraction of the wrist and elbows. We categorize this disorder under the category of RSI, repetitive stress injury. And another one common cause is diabetes and obesity. Of course, there is obesity, and the another very important cause is hypothyroidism. And this is very important. Sometimes patient comes to you with the numbness of the index and thumb, and sometimes numbness of the hand. Sometimes it may be radiating to the arm or forearm. So even the patient comes to you with these symptoms, we have to check the thyroid level, because maybe this may be the only symptom due to that hypothyroidism. So when a patient comes to you, especially with the carpal tunnel syndrome, you should rule out the thyroid or hypothyroidism, definitely. And another cause for this type of entrapment neuropathies, of course, arthritis, rheumatoid arthritis, and some that's arthritis causing swelling and synovial fluid accumulation that will cause some entrapment neuropathies, that is arthritis. And if there is some underlying peripheral neuropathies leading to nerve hypertrophy, like in leprosy, if there is nerve hypertrophy, it will compress on the undergoing structure. So that is also a cause for the this type of mononeuropathy. So our aim should be, if the patient comes to you with the carpal tunnel syndrome or whatever may be the mononeuropathy, You just identify the cause behind it, because the treatment strictly based on the causative mechanism. Otherwise, the patient will not respond to the treatment. The patient will again come to you with no response. But if you are identifying the causative mechanism behind behind the carpal tunnel syndrome, or behind the modern this type mononeuropathies, we are able to treat that case very genuinely. So this type of causes we have to know: RSI, diabetes, obesity, hypothyroidism, arthritis, etc. And we are entering to the polyneuropathy category. So mononeuropathy is over, and we are moving to the polyneuropathies category, and we are symmetrical generalized polyneuropathies. And main mechanism is neuropathies associated with the metabolic diseases. Neuropathies associated with some metabolic issues. The most common metabolic issue is diabetes mellitus itself. So diabetic neuropathy or diabetic polyneuropathy is a very common condition, common disorder that patients comes to our OPD for seeking the treatment, where many treatments are failed. Because even in modern medicine also, they are giving gabapentin or something. Sometimes it will not be effective in many cases. So the patients are coming to the OPDs. So that is very important to know. So the diabetic polyneuropathy is a neuropathy coming under the metabolic diseases. And the hypothyroidism usually causing motor mononeuropathies or entrapment neuropathies. But in some cases, it may cause polyneuropathies. And another important finding is when the patients comes to with some polyneuropathy pattern, we have to check whether the patient is vegetarian or not. If the patient is strict vegetarian, we have to check the vitamin B12. We have to doubt about the vitamin B12 deficiency, and sometimes the patient will come, if especially the patient comes to you with the predominantly motor involvement, where we have to vitamin B12 deficiency, especially in vegetarians. Okay, and in uremia, if there is renal failure or renal problems, if there is uremia, and in some cases of chronic renal failure or chronic renal diseases, and there is a chance for due to this toxic accumulation, there is nerve damage, so there is chance for polyneuropathy. And chronic liver diseases. This is also very common. The patient may present with you some neurological disturbance like pain and numbness, everything. While we are assessing the patient, we may get some evidence of the, especially in older individuals, chronic liver diseases we will get. So these type of metabolic disease or system disorders we have to know while we are treating a neuropathy case, especially with numbness or sensory or motor symptoms. So this is the neuropathy associated with the metabolic diseases. And as a common, we have diabetic neuropathy, and there are a lot of variations or pattern of different variations can be seen in diabetes mellitus. So that is worth discussing here. That is why I'm discussing here. Neuropathy associated with the diabetes. There are different varieties or different pattern of involvement in sensory nerves. So first one is the very common type is distal symmetrical sensory motor polyneuropathy. That is glove and stocking type of polyneuropathy, where the patients will experience this type of hand and feet numbness, as we told in Purvarupa of Prameha, Karapadadaha. It's a very common finding. That is why it is told in Purvarupa. Even the pre-diabetic stage or in the even detecting the diabetes, the patient may experience the types of, especially in type 2 diabetes, there is a chance to develop early neuropathies. So in our classical text, it's mentioned in Purvarupa. So some importance is there. So distal symmetric sensory motor polyneuropathy. And another one is autonomic neuropathy. Many patients, especially patients comes with constipation, patients comes with urinary retention and some orthostatic hypotension. This is also very common. So autonomic neuropathy is very common. And diabetic polyradiculoneuropathy. That is very important because the patients comes to you with the features of the IVDP, disc herniation or disc problem on the both legs or something like, or both hands. If there is no evidence of the disc lesions, the main cause, if the patient is diabetic and if he or she with the poor glycemic control, diabetic polyradicular neuropathy is a very common in this type of patients, and where we have to consider this aspect also. And another one is that sometimes the patients comes to you with proximal weakness, especially in the thigh muscle weakness and severe pain in the thigh region, and it's uncontrolled diabetes or long-standing diabetes. There is a chance, we call it as diabetic amyotrophy. And even in lumbosacral radiculoplexopathy, even the lumbosacral area, if there is, in some patients comes to you with the shoulder joint involvement or shoulder group of muscles or proximal group of the upper limb muscles involvement in diabetic amyotrophy. It's also very common, like in diabetic shoulder, start with the diabetic shoulder, and sometimes amyotrophy may be seen or muscle weakness may be seen. So in diabetic patients, it is very important, and it is common also, asymmetric painful lumbosacral radiculoplexopathy. It is a very common in lumbosacral area. That is why it is called the lumbosacral radiculoplexopathy or brachial plexus or plexus involvement. It is called diabetic amyotrophy, but nowadays it is very common in the upper extremities like the shoulder region also. So that we have to be focusing. And symmetric painless polyradiculopathy. This is also important. The patient comes to you with the radiculopathy with the motor weakness, and there will not be pain, there will not be any pain, but patients comes to motor weakness, and it is in a radicular distribution. So this is also there is a chance possibility of the diabetes, symmetric painless polyradicular neuropathy. And very common focal mononeuropathies, especially cranial neuropathies, especially facial nerve, especially abducens nerve palsy, sometimes trigeminal nerve palsy, trigeminal neuralgia. So these are the common focal mononeuropathies. And entrapment neuropathies like carpal tunnel syndrome. And these are the very common conditions in diabetes. And in some cases, there is diabetic small fiber neuropathy. So see how this diabetes is causing all the peripheral nervous system. Different forms and different varieties of disorders can be related to the diabetes mellitus. So our focus and in neuropathy, our focus, we have to more focus on this type of disorders as associated with the metabolic disease or systemic disorder, especially diabetes. So this is very important here. And the another one is immune-mediated inflammatory neuropathies, inflammatory immune-mediated inflammatory neuropathies, where the common cause is Guillain-Barré syndrome. We all know that term Guillain-Barré syndrome. Guillain-Barré syndrome, otherwise called acute inflammatory demyelinating polyneuropathy. So in Guillain-Barré syndrome, the course of the progression of the illness will be within weeks, within 2 weeks or maximum 3 weeks. So that is called acute inflammatory demyelinating polyneuropathy. And the patient, typically the classical presentation is starting with the distally and the ascending, is called ascending paralysis. So starting with the distally, and it will spread to the in an ascending way, distal to the proximal. And in some cases, but many cases are presenting with the proximal weakness also. So the typical presentation is distal to proximal ascending paralysis, but in some cases there is proximal involvement. If there is proximal involvement, if you have seen the proximal involvement first, there is a tendency to develop respiratory insufficiency and bulbar muscle involvement, where we have to be more careful about the respiratory insufficiency. But other types of distal to proximal group, it is almost easily manageable, or we can treat that type of cases accordingly. Okay. And another variant of the Guillain-Barré is Miller-Fisher syndrome, where ataxia, areflexia, and ophthalmoplegia is a common finding. And in some cases, even though we are discussing the demyelinating polyneuropathy, the Guillain-Barré or the inflammatory demyelinating polyneuropathies, in some cases, especially in India and in Asia, there is some axonal forms also that we call it as acute motor axonal neuropathy and acute motor sensory axonal neuropathy. So these are the rare findings there, but the very common finding is acute inflammatory demyelinating, where the patient will be acute course. And if this is if the same pathological mechanism in a chronic course or in a progressive course with a remitting relapsing nature, we call it as chronic inflammatory demyelinating polyneuropathy. where the patient will give history a progressive distal weakness and sensory symptoms with areflexia or maybe or with reflex or with loss of reflex. In a progressive course, about it's a 2 months or 3 month course, it is called chronic inflammatory demyelinating polyneuropathy, and it has a tendency to remitting and relapsing nature. So it's an immune mediated or autoimmune mechanism. There is pathological autoimmune mechanism. And another one is multifocal motor neuropathy. It is also immune mediated inflammatory demyelinating neuropathy. And this type of neuropathy, we have to differentiate from the motor neuron disease, because in motor neuron disease and in multifocal motor neuropathy, only the common presentation will be there, because there will be motor weakness only, no sensory involvement. And the multifocal motor neuropathy is somewhat treatable, easily treated, but the MND is slowly progressive devastating disorder. So we have to differentiate the multifocal motor neuropathy from the motor neuron disease. There are different mechanisms, and in multifocal motor neuropathies, the immunoglobulins, especially IgM level, may be raised, and due to some immunological reactions, some findings can be seen, and conduction block can be seen. And in MND, in the electrophysiological studies, we will get some different pattern. So, and another one is paraproteinemic neuropathy. In paraproteinemic, you just know the names, because there are a lot of causes and a lot of pathological mechanism behind the neurological disorder that we have to know. Paraproteinemic neuropathy, it's very commonly called monoclonal gammopathy, where IgM or IgA, especially very common is IgM, and IgM levels are raised, and it will cause paraproteinemia, and it may lead to the neuropathy, where we have a laboratory test and everything to identify this type of monoclonal. We can identify the paraproteins in the urine or paraproteins in the blood. And it is very common in some myeloproliferative disorders like multiple myeloma and some lymphomas. Like it is associated with this type of paraproteinemic neuropathy is associated with some type of cancers like plasmacytoma or multiple myeloma or this type of cases. Okay, this is paraproteinemic neuropathy. And another important one is vasculitic neuropathy. Vasculitic neuropathy. This is an immune-mediated disorder directed against blood vessels, resulting in ischemia and infarction to the peripheral nervous system. So, where due to vasculitis of the vasa nervorum or blood vessels to the nerve, there will be due to ischemia, there will be damage to the nerve. The clinical presentation may usually it's multiple mononeuropathies. As we have discussed, there will be multiple involvement of single nerves in the body. That is called multiple mononeuropathies. Otherwise, it is called mononeuritis multiplex. And it is a very common condition. It is very closely related to some rheumatological conditions, like SLE, rheumatoid arthritis. So vasculitis is very common in some this type of rheumatological disorders, and also some vasculitic disorders like DIC, etc., etc. So vasculitic neuropathy is also very common in our condition, in our clinical settings. And vasculitic neuropathy, we have to diagnose based on the neurobiopsy also. After electrophysiological studies, we have to go for nerve biopsy for vasculitic neuropathy. Then only we can identify the exact mechanism or exact pathological aspect of the vasculitis. So nerve biopsy is a very common, we are doing, especially from the sural nerve, we are doing this nerve biopsy for, especially to identify the vasculitis. Okay. And another cause is, which is very common also, hereditary neuropathy. In hereditary neuropathy, we call it as CMT, Charcot-Marie-Tooth disease, where we will get hereditary motor and sensory neuropathies, HMSN. And in this, there will be bilateral distal weakness and wasting of the calf and leg muscles, and with the pes cavus, arching of the foot, and hammer toes, etc. So some deformities will be there, and there will be that we call it as inverted champagne bottle, like the appearance is like inverted champagne bottle. So like we will use that term for this type of weakness. There will be bilateral distal weakness of the legs with the wasting of the leg and calf muscles, with some pes cavus and the hamarto deformities. This is also very common. Charcot-Marie-Tooth disease, and when this we are able to diagnose this case, there is a hereditary tendency, and we have to be careful about the hereditary and genetic level. Okay. And some toxic neuropathies. Toxic neuropathies, there is some drugs and some metals and some alcohol use will cause toxic neuropathy. Especially anti-cancerous drugs, anti-cancer or chemotherapy drugs will cause like cisplatin, will cause sensory neuronopathy, predominantly large fiber. And amiodarone is using for as an antiarrhythmic, and it is also causing this type of polyneuropathies. For demyelination is the main cause. And colchicine we are using for the gouty arthritis or to reduce the uric acid level, and it is very related. It is very commonly related to chronic use will lead to the myopathy and proximal weakness and myopathy, and sometimes the neuropathy. And axonal degeneration is the cause. And lead neuropathy is due to inhalation or ingestion of the lead particles from different settings. There is axonal degeneration is done, and lead neuropathies. In pain, we have seen some cases in paint workers. In paint workers, the patients presenting with this type of distal sensory and motor weakness. And while we are identifying the etiology, it was due to lead poisoning. And another very common condition, that is alcohol, excess alcoholism will cause slowly progressive paresthesia, numbness and burning pain, more severe in legs, and autonomic dysfunction is also common. And generalized sensory motor primary axonal polyneuropathy is the culprit. So alcohol is also causing neuropathy, and it is in when there is excess intake of alcohol, or a patient is addicted to alcohol, there is the chance to develop the alcoholic neuropathy, and it is also very common in our clinical settings. And some autoimmune diseases that are will cause this is I am discussing here because the patient will present you to only the neuropathic symptoms, but the underlying mechanism will be different. That is why I am discussing here. Autoimmune diseases that are causing neuropathy, that is the main one. The main thing is rheumatoid arthritis and the Sjogren syndrome with rheumatoid arthritis plus this parotid gland dryness of the trees, everything, and salivary gland. And systemic lupus erythematosus also is a very common with the neuropathy, and sarcoidosis is very common with the neuropathy. And inflammatory bowel diseases like Crohn's disease is also very common with the neuropathies. So this is this I am discussing here because these type of cases are increasingly seeking medical attention from the Ayurvedic system. So we have to know, we have to identify the underlying mechanism. Then we have to treat the case in this type of neuropathy. So many factors has to be considered while we are treating a numbness or simple numbness or simple burning sensation or simple weakness. We have to consider a lot of things here that we have to identify. That is I am discussing here. That is autoimmune diseases that are causing rheumatoid arthritis, Sjogren syndrome, SLE, etc. And some infections. See how these infections are causing the neuropathies. In leprosy, we have seen this. There is greater auricular nerve thickening. It's a very common finding in leprosy, and there will be nerve thickening, and the neuropathy is very common in leprosy, and it is seen in developing countries like India, in several parts of India. So that is also. And Lyme disease. Lyme disease is a tick disorder, and it is also a main clinical features of the Lyme disease is this polyneuropathy. That is the polyneuropathy, and sometimes the patient presents with mononeuropathy also. And the causative agent, causative organism is Borrelia. We know that. And diphtheritic, due to diphtheria, there is chance for neuropathy. And HIV also. And it is nowadays in several countries, several parts of India, even the patients comes to the clinic with the numbness and the paresthesias and numbness. While they are testing for this HIV is found to be positive. So even in negative, if there is if you are suspecting such possibilities, we have to check the we have to do the blood test for the HIV. So HIV is also very common with the neuropathies. And some malignancy is causing that's cancer will cause neuropathies, paraneoplastic neuropathy. And this is important because in paraneoplastic neuropathy, especially in lung cancer, odd cell carcinoma or small lung carcinoma, even before the paraneoplastic means this cancerous cancerous growth will exhibit a will initiate a immune mechanism due to some immunoglobulins or hyperactive immune response, and it will attack the nerves and it will cause neuropathy. So even in the beginning stage of some cancer, the patient may present with the polyneuropathy, and it is also to be noted here, paraneoplastic neuropathy. It is very common in lung cancer. And neuropathy to secondary to tumor infiltration. In some cases like lymphoma and leukemia, the tumor may infiltrate to the nerves and it will cause neuropathy. It is very common with the lymphomas. And peripheral neuropathy associated with the lymphoproliferative disorders. We have discussed that is multiple myeloma, plasmacytoma, and so many disorders like lymphocytic leukemia. So many cases are there. And due to this type of cancer growth, there will be a chance for peripheral neuropathy. Okay, so these are the main causes due to infection, due to cancer, and due to metabolic disorders, and due to inflammatory immune-mediated autoimmune mechanism. So when we are treating a case with the polyneuropathy or neuropathy, we have to analyze the underlying mechanism and underlying cause behind the problem. So then only we will get good result while we are doing this treatment. And we have to follow the investigations. Definitely, we have to follow the investigation. And I'm not dealing with all the investigation. It is time consuming. So where we have to focus the blood investigations to identify the underlying cause. So where we have to look for CBC, for anemia, everything, and CRP to rule out inflammatory conditions or infections, biochemistry, hormones, vitamins, especially vitamin B12 and vitamin B1, and immunological and rheumatological mechanisms, all on the IgM, serum, immunoglobulins, and anti-nuclear antibodies, RF factor, anti-CCP, etc., etc. So all the possible mechanisms to be ruled out by these blood investigations, where when we are suspecting based on the clinical pattern, symmetry involvement, and mononeuropathy, whether we differentiate mononeuropathy and polyneuropathy, and it is symmetrical distal. So based on these findings, we will get a clue about the underlying mechanism, where we have to ensure that the underlying mechanism is due to this factor. We have to know the blood investigations, where we will test, we will give the blood to in a proper way based on if there is, we are suspecting autoimmune etiology, we have to test for immunological and rheumatological studies. When we are suspecting a case of nutritional problem, we have to do these vitamins. And when we are suspecting hypothyroidism, we have to go for thyroid level. So these are the main mechanisms. These are the main factors to be identified in the blood test. And in every cases, it is very important to do the nerve conduction study and EMG, where we can differentiate the neuropathy from axonal and demyelinating, and where we will get a clue to the site of lesion, everything. So, for example, in axonal neuropathy, the amplitude in NCV will get amplitude low in axonal neuropathy, and distal latency, there is a distal latency prolonged in distal demyelinating neuropathy and compression neuropathy. So by this mechanism, we are able to differentiate this axonal neuropathy and demyelinating neuropathy. And the conduction velocity is reduced in demyelinating neuropathy. So thereby itself, we can differentiate this demyelinating and axonal. And by analyzing the EMG, we can differentiate myopathic pattern and neuropathic pattern. And in myopathy, there will be different pattern, and in neuropathy, there will be EMG pattern will be different. So there will be, we can see In myopathy, there will be in inflammatory condition, fibrillations and positive waves. But in neuropathy, there will be fibrillation, spontaneous activity. So there are some difference. We can see that difference. I'm not going through this, it's time consuming. So NCV and EMG, basically we can differentiate it's neurons involved or neuropathic pattern. And in neuropathy, we can differentiate axonal or demyelination or mixed type, that we can differentiate from the NCV. And in some cases, we need muscle biopsy also or nerve biopsy also to differentiate other possible mechanisms like vasculitic neuropathy or in sarcoidosis. Vasculitis, the main mechanism identifying by the nerve biopsy is vasculitis, right? Vasculitis. If there is vasculitis, we have to, there are the treatment difference, so that we can discuss now. Okay. And CSF study, especially in GBS, Guillain-Barré syndrome, and in multiple sclerosis, CIDP, etc. We have to know the CSF. We have to know the CSF analysis where the proteins are low protein, CSF proteins are very low. Thereby, we can identify or we can we will get conclusive evidence about the Guillain-Barré syndrome, etc. So in some cases, we need CSF study also. So especially in Guillain-Barré syndrome, but it is not routinely done, but in some special cases or some suspected cases of the infections like meningitis, encephalitis or neurosyphilis, or in some cases of Guillain-Barré, multiple sclerosis, or in transverse myelitis, we are doing this. And we know just as a we can do just a DANG therapist. We just memorize the term DANG therapist. So we will get etiological factors of the peripheral neuropathy. D for diabetes mellitus, and A for alcohol, and N for nutritional, especially B12, and G for Guillain-Barré, and T for toxins, lead, arsenic, etc. And H for hematological, like paraproteinemia, as we have discussed, and E for endocrine, especially hypothyroid, and R for rheumatology, SLE, rheumatoid arthritis, vasculitis, etc., and A for amyloid, porphyria, and infectious, example HIV, and sarcoid, and some tumors, paraneoplastic neuropathy. So by saying this, you just memorize the term DANG therapist, thereby all the causative mechanism, almost causative factors are included under this term. Okay, so just know the causative mechanism behind this. Now we are moving to Ayurvedic diagnostic considerations and management. Am I audible? Is it clear now?
Yes, doctor, you are audible.
Yeah, okay. So let's move to the, now up to this point, we have discussed the modern diagnostic considerations and diagnostic methods, and where we have to know the importance of the electrophysiological and pathophysiological mechanism behind the neuropathy, especially axonal or demyelinating, or whether it is due to diabetes, or whether it is due to hypothyroidism, or whether it is other immunological mechanism due to. So, so many factors has to be considered while we are treating a case. So this is very important. That is why I have discussed this modern aspects up to this point. Okay. Then we are moving to Ayurvedic diagnostic consideration and management. So why I have discussed this mechanism, because where in Ayurvedic management also we have to consider all these factors. See, we know it's a snayu, it's sira, it's kandara, but many terms are used. But basically what is happening in there is a derangement of Vata Kapha Dhatu axis. So the nerve conduction is actually a Vata Kapha processed through a Vata Kapha Dhatu axis. Dhatu is there, or Ubadhatu is there, and it is conducting by the Vata Kapha. Okay, so Vata Kapha Dhatu axis derangement is the main cause for the this type of neuropathy or whatever may be the neurological disorders. So apart from Vada Vyadhi, we are thinking this neuropathies or this type of neurological disorders in a different way where we have to consider all these factors. So derangement of Vata, Kapha, Dhatu axis is there. And of course, in every cases, there is in vasculitis or in autoimmune etiology or in inflammatory, whatever may be the cause, there is Dhattvagni Mandya. So Agni Mandya is at the Dhatu level or Dhatu Agni level. So we have to correct the pathology by correcting the Dhatu Agni, and as it is Dhatu and Upadhatu involvement, after correcting the Dhatu Agni, we have to do Rasayana. Then only Dhatu will be in a proper way. So that is very important. And Malasanjaya, we know in many neuronal tissues, the tissue damage is due to some intracellular accumulations. Free radical injury, whatever, free radical injury or inflammatory process. So the Malasanjaya concept we have discussed in AMA, or we know it is evident in AMA. So AMA formation at the Dhatu level or Upadhatu level or Malasanjaya. So Malasanjaya also, especially in toxic neuropathies, alcoholic neuropathies, lead toxicity. So these are causing Malasanjaya or Visha, or this is causing toxic accumulations in the nerve and it is damaging the nerve. So Malasanjaya also a very good role in this type of cases. And another one is Kapha Dushti and Pitta Dushti in Madhyama Raga Marga. This we have to know because in if all the neurological, especially this type of neuropathies, are coming under the category of the Madhyama Raga Marga, and almost all diseases in Madhyama Raga Marga is Vada predominant. So the patients comes to you with Vada predominant features, where we will mislead that case into a Vada predominant stage where we'll go for Brahmana. So if there is Avarana, the Brahmana will get Anubhava and the patient will get may worsen. So identifying that Kapha Dushti and Pitta Dushti in Madhyama Raga Marga is very crucial. That is very important in this type of cases because especially Pitta Dushti, we have to identify the Pitta Dushti in Madhyama Raga Marga by the pathological mechanism itself. Because Pitta Dushti, if there is Pitta Dushti, the treatment we are giving may aggravate the symptoms, especially the Swedana procedures that we have discussed in the introductory class, introductory portion where Utto phenomenon or Swedana, contraindication of Swedana and heat intolerance in this type of demyelinating polyneuropathies. So this is an important concept where we should able to identify the Kapha Dushti or Pitta Dushti, Kaphavarana and Pitta Avarana, either by Upashya or either by this investigative mechanism. Because the clinical features almost, the patient comes to you with the clinical features of almost Vada Dushti. There will not be any evidence of clinical features of Kapha Dushti. But the pathology or the samprapti of Kapha Dushti and Pitta Dushti is hide in the Madhyama Raga Marga. So that we have to know. And of course, if there is autoimmunity and if there is immunological mechanism is involved, Ojo Dushti we have to consider. Ojo Visramsa or Ojo Dushti we have to consider. And we know that the Ojo Dushti, Ojo Visramsa and Ojo Vyabhat, it is nothing other than hyperactive immune response to the body. When we are going through the symptoms of the Ojo Dushti and Ojo Vyabhat, it is nothing but hyperactive immune response. So while we are treating such cases, we have to know the Ojo Dushti level. If there is Ojo Dushti, we have to consider the Ojas also, where we have to treat the Ojo Dushti in terms of Pitta and Vadarekta approach that we will discuss. And of course, Visha. Visha is causing cellular accumulation, cellular toxicity, and that will damage nerve, as we have discussed in lead neuropathy and some anti-cancerous drug and some alcohol, etc. So Visha also very important. So based on these factors, we have to modify or we have to make the protocol of the treatment. Okay. So in Bija Dushti, if there is like hereditary neuropathies, we have to consider the Bija Dushti. So as a whole, if there is Daduchya and Avarana or Avaranajanya Daduchya is the pathological mechanism. So all these factors like rearrangement of Vada Kapha Dhatu axis, all are factors related to Avarana. So Avarana can be in different ways, in many ways that we have discussed already. So we have to know or we have to identify the Avarana by either by the Upashya technique or by the this type of cases. So even though it is Nayu Sera Gada Vada, we have to consider all these mechanisms here. So So these are the conditions. Okay. And when coming to neuropathies, axonal degeneration, when there is axon, so I'm giving the concept. I'm not. I will go through some medicines that we are giving here and some. Okay, but it's not the final. It's the final one. We have to know the exact mechanism and we have to treat accordingly. So axonal degeneration, if there is, we have to think about the Kabha-Vradavada Chikitsa and correction of underlying cause. So if the patient is with axonal degeneration, if the neuropathy is axonal predominant, we have to consider the Kabha-Vradavada Chikitsa and correction of underlying cause. And if it is segmental demyelination, if the demyelination is the pathology as is seen in GBS, CIDP, we have to consider the Pitta Vradavada or Pitta Varanavada, where we have to treat the case like this only. So we have to consider the Pitta. So this is the basic information or basic concept of this. And if there's in some cases like in diabetes mellitus, we can see mixed type, that is Pitta Kapha, where we have to consider both Pitta and Kapha. So Pitta Kapha or the Vada Chikitsa we have to approach. And if there is autoimmune etiology, we have to focus Vada Rakta approach. So all these factors has to be considered according to the pathological mechanisms. And so for example, I'm giving, it's not the final one, it's not the final treatment method, but I am, it's my humble request to you not to follow all these, not to follow blindly these medicines, because I am giving only for an information that we are using based on the approach. That is the only method we are using. Okay. So endocrine neuropathies, depending upon the cause, if there is hypothyroidism, we have to focus the Shofahara and Pittahara, where we can use Ardhavillam Kashayam, Punarnavadi Kashayam, Kanjanara Kulu, Kaishwara Kulu, Tagam, etc. And we can use Labana with the Guluji Vatradi, Yalumishadi, etc. And where we have to, after symptoms are relieved, or we have to go for Rasayana, Maharaja Prasarani, Brahma Rasayana, Chitraga Rasayana, etc. So these are some examples. It is not the final treatment modality. So it's not, because I am giving, we have to focus on these type of cases like this, where we have to focus on Shofahara and Pittahara Chikitsa, where the patient is getting good result. So if there is hypothyroidism, we have to focus on Shofahara and Pittahara, Ardhavilla Kashaya, Punarnavadi Kashaya, etc. And it is very Maharaja Prasad as a final stage. If Shofa is okay and the patient is symptomatically getting better, we can go for nerve stimulation or nerve improvement like with the Maharaja Prasarani, and Brahma Rasayana is helping, and in some cases Chitraga Rasayana is helping. So these are the methods we have to follow. And in arthritis, if the patient is associated with if the mononeuropathy or entrapment neuropathy is associated with arthritis, there we have to focus on Vada Raktahara and Pittahara. If the patient is so where we are focused, we will give kashayas like Shadavyadi, Rasna Saptaka, Amurdaga Gulu, Simhanada Gulu, Mahayagaraja Somnagulu. So it's found to be very effective in this type of arthritis related neuropathies. That is, I am giving this. And Laba with Jadamyadi, etc. And Rasayana, if there is arthritis, we can give, if there is no diabetes, Chavana Prasha. And Maharaja Prasarani Taila is very good drug. And Karaskara Taila or Grida, especially if it is associated with, and Guluji Sator, Guluji Rasayana, etc. can be given as Rasayana. It's not all the drugs are not Rasayana, but we can give these drugs as Rasayana. That is very important. And so this is the method. So that we have to follow. So if there is arthritis, the arthritis approach will be there, and where we have to modify the drugs based on the Vada Rakta Chikitsa and Pittahara Chikitsa. And if there is hypothyroidism, we have to focus on Shofahara and Pittahara Chikitsa. See that difference. And in where we can change every aspect in the external procedure and in the internal medication and in the Rasayana, we have that approach that we can follow. Definitely the patients are responding well, and this is and in some cases we can't identify the idiopathy. We can't identify the exact mechanism of especially carpal tunnel syndrome. Either we can call it as idiopathy, and in some cases, if this IT professionals due to if it is due to RSI, where we can focus on Agnikarma. So where we have to do Agnikarma in carpal tunnel syndrome, when the patient is presenting with the carpal tunnel syndrome is either due to RSI, repetitive stress injuries, or if there is no specific mechanism is seen, we can stimulate or we can give the counter rotation with the Agnikarma, and in that cases, Agnikarma is found to be very effective. And for example, next level, we are moving to the polyneuropathies, and in some conditions, I am discussing. It is diabetic neuropathy. So in diabetic neuropathy, where we have to consider the diabetes, and it's a mixed axonal and demyelinating. So where we have to consider, sometimes we have to consider the pitta and kapha simultaneously, and where we have to give treatment accordingly based on the symptoms, pitta predominant or kapha predominant, where we have to focus. So in diabetic neuropathy, internal, we can give Nishagadagadi, and Nishagadagadi Kashaya is very good drug. It is also controlling the diabetes, but it is actually, in my opinion, it is very good drug or very good Kashaya to control the diabetic complications, especially neuropathy. This is very important. Okay. And another one is if the diabetes mellitus is associated with some vasculitis or some ischemic changes to the nerve, the Kashaya with the Goluji, Panalveri, the botanical name I am giving, the Panalveri is a Malayalam name, Glycosmiss pendaphylla, and Sahajara. So this combination is, we can give in PVD also, peripheral vascular disorders. So in peripheral vascular disorders and in some cases of diabetes mellitus associated neuropathies, this Kashaya, if there is evidence of vasculitis or if there is evidence of PVD, peripheral vascular disorders, we can give Kashaya with Guluji, Panalveri, and Sahajara. It's a very good combination, and it is very working in a good way. And Triphala Chitraka Chorna, Triphala Annabheti Sindhura, Vyashadi Kukulu, Triphala Kukulu. And another good one is Shira Guluji. We are making like Shirabala, we are making Guluji Shira. So this is Thailam. Instead of Bala, we are using Guluji. That is also a very good option for this type of diabetic neuropathy. And while we are applying lab procedures or external procedures, I am giving some examples, not the all procedures. So where we are using focus to the Kaba Shamana or Kabahara. So Gunja, Laba with the Gunja, Darvi, Devadara, and Yellu we can use, or Tila we can use. And Dhanyamladara is a very good option. And Karaskara Estimadu Dashamula Shiradara is very good option, and Triphala Estimadu Kashayadhara and Abhinda with the Gajida Pindadaila. Instead of using Pindadaila, Gajida Pindadaila is somewhat more effective in this type of cases when there is indication of Snehana Prayoga. And if there is Rasayana, in case of Rasayana, we can focus Chitraga Rasayana, Lashna Rasayana, and see the Abrabhasma. Abrabhasma is found to be very effective in some case, this type of diabetic polyneuropathies, and it helps to reduce the symptoms, and also it will rejuvenate the nerve. So Abrabhasma, when we should be careful about when we are giving Abrabhasma, there should be specific dosage and specific time also. And Shilajadu Rasayana is also very good in this type of, it's also control the diabetes and also for the control the diabetic complications. And when we are giving Shilajadu Rasayana and Abrabhasma, if the patient is with chronic kidney diseases or kidney failure, we have to be more careful. Okay, that's all. And demyelinating polyneuropathy. So how we will treat the demyelinating neuropathies like Guillain-Barré syndrome. So diabetic polyneuropathy we have discussed, entrapment neuropathy we have discussed, but something different in demyelinating neuropathy. So see the difference. if you are able to differentiate this axonal or demyelinating, the treatment is changing and the medicines are changing and the applications are changing. Where in demyelinating polyneuropathies, we do pitta shamana. Don't give more heat, don't give swedana. Swedana is contraindicated. Means excessive swedana, excessive sweating, or excessive hot applications is contraindicated. While we are giving dhara, you use the drug with the pitta shamana. That is very important in this type of cases, and that we have to be very careful and cautious about this. Okay. And in demyelinating type, we can use Shadaviryadi Kashaya is a very good option, and another good option is Drakshadi, and Rasa Sindhura we can use Saptamrta Loha. And if there is Autoimmune level problems, Dushi Vishari, this Dushi Vishari we can use in alcoholic or toxic neuropathies also. And while we are using external therapy, you just select the drugs like the Pitta Shamana, Eshtimadu, Haridra, Daru Haridra, Gulu, Jitila, etc. And Shiradhara with Eshtimadu, Trifala, plus Trifala or Nalpamara, Gajida Bandadila, Abhyanga may be used. And don't go for this Pirichil or Kayasega or other kiddies like say Chorna Pendaseda or Patra Podala Seda. Don't give much Sedana. But in the later stage, we can use Shastika Lavana. Don't give Swedana or don't give Shastika Pinda Sweda, but you can give Shastika Lavana. And Shastika Lavana is much effective in this type of cases, especially in MS and especially in demyelinating neuropathy. Okay, so this is very important to know. While we are treating the demyelinating neuropathy, it is very important to know where the extensive Swedana procedures are contraindicated. In many cases, the patients are even after taking history, while we are the patient approaching the hospital, if they are done some Ayurvedic treatments, they are telling after the Ayurvedic treatment, the symptoms aggravated, especially multiple sclerosis, especially this Guillain-Barré syndrome, because this type of extensive Swedana procedures. Okay, so this is very important. And when we are doing in demyelinating neuropathies, especially, so we can do some Panchakarma also. I'm just giving some clue. That is Kshiravasti is a good option, and Guluchadi Kashayavasti, Mustadi Yabanavasti, that is also very effective in this type of. So there are a lot of treatment options other than Swedana that we can follow in this type of cases. And Rasayana, while we are doing Trifala Guluji, we can do, and Yashtimadu we can do, and Shadavari. So Shadavari is very important because Shadavari has a natural steroid property, steroidal property. So the preparations of Shadavari along with other drugs like Dhanandrangruda or like with Chanaprasha, Shadavari, Churna or Shadavari, we can give Shadavari in a controlled manner, but Shadavari is getting good result in demyelinating type of neuropathies, and also Abhravasma is also getting good result. And vasculitic neuropathy, where we have to Vada, Rekta and Kabhavrada Vada Chikitsa. If it is the patient is presenting you with the vasculitic neuropathy, this type of cases can be seen in some diabetes mellitus. So if there is vasculitic neuropathy, Vadarekta and Kabhavrada Vada Chikitsa, Rasana Panchakam Kashaya with the, and this is very important. See that Kashaya. If there is autoimmune etiology, and if there is something related to vasculitis or autoimmune or immune mediated mechanism, we are using this Kashaya with the Padola Shariba Musta Pada Kadirohim. This is actually told in, actually explained in Dhadugata Jara Chikitsa or in Sandadadi Jara. The second line goes like Kalinga Padola Subatin, the first line, and second line is Padola Shariba Musta, where it is Sadada Jara, where Rekta Dhadu is involved. So if there is a hyperactive immune response or Dhataknima Dhadu, Rekta Dhadu level or Rekta Dushti is evident, especially in autoimmune disorders, hyperactive immune responses, hypersensitivity reactions, and we can use this type of Kashaya. It is very good, it is yielding good result. And Ashtavargam Kashaya. And as I told you, if there is vasculitis, if there is ischemia to the blood vessels, we can use Sahajara, Guluji, Panel Veri Kashaya, Simhadada Gugula, and a lot of options, Trifala, Chitraga, Sahajaradi, and in especially in this type of vasculitic neuropathy, after some day we can give Sahajaradi Avarti, and we can give Karpasastadi Avarti, etc. And we can use Ulsadhana or Leba with the Kolakulatadi, and the Rasayana where we can use Chitraka Rasayana, Lashuna Rasayana, Shilajat Rasayana, Abravasma, etc. So these are the treatment modalities or treatment methods that we are adopting in different neuropathies by identifying the axonal or demyelination. So this is a humble, simple attempt to give some differentiation and differentiating the pathological mechanisms, thereby the difference in treatment modalities. So let me conclude this session and thank you all for the patient listening. And if you have any doubts, please, I will try to clarify. If I am no, I will clarify. Thank you.
Thank you, sir. So the participants can put their queries or doubts in the chat box. And before going to the discussion, I would like to welcome Dr. Mohammed Yasif, Factory in Charge, Dr. B. Alikutis Kottakkal Ayurveda Pharmacy, Kottakkal.
Myself, Dr. Mohammed Yasif, on behalf of Dr. P. Alikutis Kottakkal Ayurveda Pharmacy. Thanks, Dr. Mirdaz, for giving a good session. That's a valuable knowledge sharing. I'm using this time for a few minutes for introducing our pharmacy or our products. We are manufacturing almost all major classical products as well as around 50 proprietary medicine also. And also we have some supporting instruments for doctors, for clinics and hospitals, and glycerin syringes for Vasti purpose, for Sneha Vasti purpose. And we are focusing all major doctors and clinics, hospitals for especially their special medicine and classical, pure classical medicine. By providing all good benefits and quality medicines also. So please contact with Dr. Jasur for further product or for further needings of that product. Thanks once again. Thanks for all. Okay.
Thank you, Dr. Yasif. So, Doctor, shall we move to discussion?
Any doubts?
Yeah, Doctor, it is in question answer section. Hello?
Yes.
Yeah. So, what would be the probable reason behind the aggravation of symptoms in demyelinating neuropathy with Swedana?
Okay. That we call it as Utto phenomenon. It is explained in multiple sclerosis, because in demyelinating pathologies, it is a complex mechanism which is what is causing this Swedana, this Utto phenomenon. The patient experience, especially with the MS or demyelinating neuropathies, the patient will experience heat intolerance, especially hot atmosphere, hot season, and in hot tub, hot water bath, fever. The patients are getting increasing this aggravating symptoms. The exact mechanism is not identified. The proposed theory is this heat is causing further block in the demyelinating fibers, and it is reducing the conduction velocity, thereby the patient is experiencing. It is well explained by the Utto phenomenon, say, explained by one scientist in ophthalmology. He experienced that the patient presenting with the heat intolerance and reduced vision in MS cases, multiple sclerosis, neuromyelitis optica, and also in neuromyelitis. So this is the reason behind that. Heat intolerance is there. Swayadana procedures is also a hot application, you know that. So that is why this heat intolerance is causing in aggravation of the symptoms. And extensive Swayadana is dangerous. That's all. Okay. If you are doing some dhara or some use the drug with pitta shamana, so there will not be any issue. I don't give more heat.
Can we do cupping in neuropathies?
Cupping, hijama, you mean hijama?
Yeah.
Yeah, cupping we can do in some cases of where Vadarekta, if there is Vadarekta etiology. Otherwise, no need. We can do cupping in if there is immunological or as we are suspecting Dakta Dushti, we can do. No.
Okay, and Agnikarma also we can do that.
Agnikarma we can do, especially by identifying the exact mechanism, because if you are doing hypothyroidism, there will not be any effect. But in RSI and in some idiopathic causes, there will be effect. And it is effective. Agnikarma is effective in some cases.
Okay, then what we have to diagnose? We have to diagnose the disease. What would be our first preference?
First preference should be history and examination. So first we have discussed, after history and examination, we should differentiate whether it is mononeuropathy or polyneuropathy. And if it is polyneuropathy, whether it is distal predominant or proximal predominant. And your neuropathies are usually distal predominant. And it is the distal predominant polyneuropathy, we have a clue. See, we have a clue like metabolic neuropathies, toxic neuropathies, etc. So based on these findings, we have to do the blood test and investigations. And we do NCV and EMG to identify the demyelinating or axonal type.
Then, in general, what is the line of treatment at first sight? That patient is sharing a case, and he had a patient with asymptomatic burning sensation in the legs with pain in hip joint on insulin treatment.
Once more, please.
Yeah, what is the first line of treatment at first sight? There is a patient with a asymmetric burning sensation in legs with pain in hip joint.
So as we have discussed, we have to see first line of treatment. We have to identify the underlying mechanism. Definitely, if it is asymmetrical and burning, and it is a type of we have to differentiate from polyneuropathies. And if it is polyneuropathy, we have to whether it is due to diabetes or hypothyroidism or any other causes, we have to differentiate. And after differentiating, we have to treat accordingly. And if there is burning sensation, everything as a first line treatment, we do some pitta vrata vada chikitsa or pitta shamana. That's if we are not able to identify the exact mechanism, we just treat symptomatically. Okay, but if there is, because we have to do the further investigations. We have to check all the blood tests like sugar, FBS, and thyroid, and we have to do to identify whether there is any polyneuropathy or neuropathy is there. You have to identify. Then only we can give the first line of treatment.
Okay.
Right, okay.
Hello.
Yeah.
Yeah, doctor. We can do Panchakarma, and which is more affected?
Panchakarma, actually, Panchakarma we can give, and we can give Panchakarma, and it is more effective is Virajana and Vasti. Especially in Guillain-Barré and demyelinating type of Vasti is more effective than Virajana. But we have to do Virajana first, then we go for Vasti. And Vasti, while we are selecting Vasti, we have to, for example, if there is a demyelinating type, we can select the drugs like Kshiravasti. So as Vadarakta Shamana, we can do Kshiravasti. If it is diabetes mellitus, if it is diabetic polyneuropathy, we can do normal Kashaya Vasti, Yoga Vasti, etc. with specific drugs.
Okay. Then neuropathies associated with the infections. What are the precautions we can take?
If it depends on the infection. We have to treat that infection. Definitely, we have to treat that infection. If you are able to treat that infection, we will do that. We can do that. Otherwise, we have to, if the infection is not under our control, we have to refer, or we have to go for antibiotic or something. Or if it is if you are able to manage, we have to treat that infection accordingly. Especially if there is chronic infections like in leprosy or in some type of infections, we can give Nirgundyadi or Krimihara also.
Okay. Then you have told about basmas. Then what is the dose of basma? That
Basma dose.
Resaushadhis you are.
While we are giving basma, we have to follow the. For example, for Abra basma, we are giving 200 mg, one BD for 15 days. Then we will give 200 mg, one for next 15 days. So for a maximum of 1 month. And Rasa Sindhura, we are giving this 250 mg, 100 mg, that we are giving 1 BD for 1 or 2 months.
Okay. If the disease is chronic, what is our first line of treatment, whether it is Panchkarma or other?
If the disease is chronic, we have to better to do with IP management, and we have to go for the initial Shodhana therapy, then with the Shamana drugs. And the main, even though if you are not doing Panchakarma, after Mridu Shodhana or after Mridu Shodhana, we have to give Rasayana. Rasayana is the main treatment option in this type of, especially in neuropathies and on every neurological conditions. We have to focus on Rasayana, because Dhatu Samyam, we have to correct the Dhatu first. After temporal factors are removed, like Ama, Avarana, everything is removed, we have to focus on Dhatu Poshana or Ubadhatu Poshana, where the Rasayana is the main treatment. Where we don't want to do all the Rasayana drugs. We can choose the drugs and we can give it as Rasayana. For example, Abrabasma we are giving Rasayana. Trifila we are giving as Rasayana. Guluji we are giving as Rasayana. So based on the pathological evidence, pathology, we are giving different options. Okay, that's so Rasayana is the main. If you are not able to do the Panchakarma treatment, you do Mridu Shodhana, then after a certain period you start with the Rasayana. Like Chitraga Rasayana, like Lashuna Rasayana, everything. If it is Kaba predominant, if it is axonal neuropathy, we can go for like Lashuna Rasayana. If it is Pitta predominant, like demyelinating, we can do with some Trifala, Guluchi, or Shadavari, etc.
Okay. Then, sir, next is a case of 55-age male patient, and he is complaining weakness of legs, which means his legs are not able to hold his body weight since 3 months, and he is on homeopathic medication until there is no improvement, and his feet turn inward while walking due to weakness, and he is not able to move his foot thumb due to weakness, and it is noted by patient itself. There is no pain in lips, and upper body have no complaint, and no investigation has done, and neurological examination, there is Babinski sign is negative, and in medicine history, no medical history, and he has took the booster dose of COVID vaccine. And the question is, what investigation should be advised to the patient, and what could be the professional diagnosis?
Okay, the patient is complaining weakness of legs. Okay, and Actually, the doctor didn't mention that what is the, if it is true, whether it is true weakness or feeling of weakness, we have to know. So there is no power is mentioned and the reflex status, only Babinski sign is mentioned. What about the reflex? And we have to know.
Sir.
Yeah.
True weakness.
True is a true weakness. Yeah. Okay. So what is the power? Power in the lower limbs also. He didn't mention. Okay.
Yeah.
Okay. No problem. Okay. So first, if the both legs are involved, if there is weakness on both legs. So after assessing the power, if there is weakness on both legs, if the power is lost there, and if the reflex is diminished, as if Babinski said, and what about the tone, muscle tone, everything we didn't mention. Okay, then even though we have to do his MRI of the lumbosacral spine first.
Okay.
And he can advise NCV and EMG. If there is true weakness, we can confirm, because there is no, he didn't mention any pattern of muscle power is not mentioned here, and the legs weak is there, but whether both legs are equally weak or one leg is weak, that weakness is due to only. And he is telling a clue that his foot, that the big toe is he is not able to move his big toe, means there will be either it may be due to common peroneal nerve or sciatic nerve, or maybe due to lumbosacral radiculopathy, especially L5 S1 radiculopathy, L5 radiculopathy. So definitely has to do MRI of the lumbosacral spine.
So what are the blood investigation we can suggest in this case?
Blood investigations, routine blood investigations, like to rule out the inflammatory, CRP has to be done, and the CBC has to be done, and thyroid and PS, and it is and other rheumatological investigation is not needed now. After even MRI itself will give the exact diagnosis, and NCVMG will give, or MRI will give diagnosis. Most probably it will be radiculopathy.
Okay. Then next, how
Or,
can we
or
treat
spinal
herpes?
or Kodaikunner, like a Kodaikunner syndrome. So we have to rule out that. So just do the MRI.
Okay, sir. And then we can move to next question. How can we treat herpes zoster neuralgia?
The neuralgia is due to an infection, due to infection. So where we have to give antiviral therapy. We are giving antiviral therapy. We can see that there is one kashaya in Chakradatta mentioned in Paitika Jara, Nidigdhadi kashaya. If you want, I don't remember all the tracks, but I can give you the Nidiktigadi Kashaya in Chakradatta. So it is told in Pitta Jwara Chikitsa, and it is very effective in this type of viral etiological neuropathies, especially facial nerve palsy, especially herpes zoster. Or you can give simply, you can give Drakshadi Kashaya, Doshi Vishari, or Bilvadi Guliga, etc. And Nidiktigadi Kashaya is found to be effective. That you have to be prepared.
Okay. Then next question. What is the cause?
Pitta Jwara Chikitsa, simple. Okay.
Okay, sir. Then next, what is the causes of burning sensation of feet in female patients and male patient, and what would be the treatment?
Burning sensation of the male and female, we have to many causes are there, especially if the patient is in a perimenopausal age or perimenopausal or postmenopausal, that may be the cause of burning feet, or maybe the uric acid problem may be there, or plantar fasciitis may be there, or sometimes the polyneuropathy may be the cause. So that we have to roll out. So you just check the uric acid level and just take the proper history. And if it is a male, we have to suspect the plantar fasciitis or neuropathy or hyperuricemia, uric acid, high increased uric acid level.
Okay, sir. And in herpes zoster, is there any local application like labas?
Local applications we can do that. That we have told in demyelinating neuropathies, Pittahara, that is Pittahara Chikitsa, where we can use the Haridra, Daru Haridra, etc. I already mentioned in this PPT.
Okay.
And ST Madhu is very good. ST Madhu, Leba, ST Madhu is very, very good in this type of lesions. ST Madhu Leba. And if there is more itching, you can Arakodatok, you can use Arakodatok. So that's simple, we can do. And the drug, we have to treat internally. That is a very important. So you just select the drugs like Nargundyadi or Dratshadi or Nidigadi. These are the options. And you give Dushi Vishari is very good, effective, very good drug. Dushi Vishari. Or there is one drug, Vishavilvadi, that is very good drug.
Okay. So I think most of the queries are over. Yeah, one participant has raised his hand. So Aarti, you can ask your doubts directly to the faculty. Aarti, you can ask now.
Hello.
Okay.
Hello.
Hello.
Sir, actually, I want to know that the case is related to somewhat symptoms of Parkinson disease. Earlier, you have discussed the case of that.
Which case, sir? Which case, madam? That you complain of
That
weakness of legs.
55-year-old. 55-year-old.
Yeah.
So I am asking that this case is related to somewhat symptoms of Parkinson disease.
There is that is why I'm asking that there is no clue about the muscle tone and there is no clue about the muscle power. And if it is Parkinson's, there will be there will be walking difficulty will be there, but weakness is less in Parkinson's. Okay, and walking difficulty mainly due to rigidity of the muscles. Rigidity due to basal ganglia involvement, there will be rigidity or spasticity. And there will be sometimes in some cases there will be a tremor also, and muscle cramps will be more. And these are the features of the Parkinson's disease. So there is no evidence of the muscle tone, and there is no mentioning about the muscle tone, and there is no mentioning about the. But only the sign is Babinski sign is negative. From that finding we can't conclude that. It is Parkinson's. It's not related to Parkinson's, I think.
Okay, sir.
Because if it is true weakness, it is not Parkinson's. Parkinson's will not cause weakness in the early stage. He will be incapacitated, or there will be difficulty in walking only due to slowness of the activities. There will be bradykinesia, it is slowness of the activity, and rigidity will be there. And sometimes the patient complains tremor also. Tremor is not important, but the other symptoms are very important, and there will be postural instability, and also there will be slow walking, everything. And there is another clue that his foot, that big toe is not moving. There is weakness. If there is big toe weakness, that means something related to the lumbosacral area, or neuropathy or radiculopathy may be there. That is why I am suggesting initially MRI.
Okay, so actually I have to ask that which treatment we have to prefer, allopathy or Ayurveda, and comparison between them.
Okay. Especially for neurological peripheral neuropathies, it's better to do Ayurvedic treatment, especially for diabetes. Especially for diabetes, diabetic polyneuropathies, and some other neuropathies. And if there is more infection like leprosy or diphtheria, or maybe another chance of infections, or if even though if the Guillain-Barré is in a ascending paralysis with respiratory insufficiency, we have to go for allopathic treatment, because the patient should be in ICU and it should be closely monitored to prevent the respiratory paralysis. At that stage, we have to follow. Even after this stage, even after the recovery of Guillain-Barré syndrome, sometimes the patient will experience weakness. At that stage, it's better to do Ayurvedic treatment. And in many cases, the demyelinating, especially, and in CIDP, chronic inflammatory demyelinating neuropathy, we have to better do Ayurvedic treatment, because there is remitting and relapsing nature. So we have to follow Ayurvedic treatment is better. But in dangerous stage, there is a dangerous stage in Guillain-Barré where we have to adopt some extra care measures to be. So it will allopathy will be effective, and serum electrophoresis, protein process, and immunoglobulins should be administered to control the hyperactive immune response. Or they will give steroids to control the to suppress the immune system.
Okay, so sir, in allopathy we will it will show some side effects also. So what we have to do?
That we have discussed. So many drugs are causing this type of neuropathies. So at that stage, if even patients are coming, when we are giving gabapentin, there will not be any response. Even in neuropathy, allopathy, they are giving amitriptyline or gabapentin. Even with amitriptyline or even with the gabapentin patients, initially they will respond, then there will not be any further response. So at that stage itself, we can shift to Ayurvedic management, Ayurvedic treatment with this specific drugs. It is getting good result. That is why I am recommending. Diabetic polyneuropathy, we can manage easily. We can give good result with Ayurvedic management. We are treating many cases, so we are confident here.
Okay, sir.
Okay, thank you.
Thank you. And so next question is, in which condition of neuropathy we can use Dushi Vishari?
Dushi Vishari, especially if there is toxic neurotoxicity, or any, if you are suspecting any Dhatvagni Mandya, we can give Dushi Vishari. So we can give in demyelinating or in diabetic also, and in toxic neuropathies like drug-induced neuropathies, drug-induced or alcohol-induced. And Dushi Vishari actually correct the Dhatvagni Mandya. So if there is that, in any case, it's not neuropathy. In any case, if there is, even in chronic renal failure, to correct the Dhatvagni level, we will give Dushi Vishari. So it will remove the toxicity, it will improve the body function. If there is chronic liver diseases, if there is chronic renal failure, if it is associated with the neuropathy, we can give Dushi Vishari.
Okay, I think most of the queries are over. So thank you so much, sir, for patiently answering each and every questions raised by our faculties, our participants. So I would like to welcome Dr. Jasul.
Hello, sir. Thank you for your wonderful session, and it was very eye-opening in the neurological side. Okay, and I'm very glad to very glad by seeing this session, and we have good responses with the faculties also. Thank you. And one more thing, Dr. Rahmatullah, who is the managing director of this Cortical Ayurveda and Modern Hospital. He is not there. He has some connection issues with there. So this session is this total Anubhava course is sponsoring by Dr. P. Alikutti's Cortical Ayurveda Pharmacy, Cortical, and they have so many wide medicines are available. So if you need any type of this medicines, we will share the price list, and so much offers are there. So we are promoting this with and if the doctors has some more benefits also there with this pharmacy with the genuine medicines. So if you have any such inquiries, please contact us. I will be putting my phone number here so that you can WhatsApp. I will give you the price list and all the details, so that you can get. We know that in your area there is somewhat difficulty to get good medicines. So this company is related to Kerala and Kottakkal. So good medicines are available with this pharmacy. And thank you, KAP, for sponsoring this session also. Thank you. Over to you, Dr. Anjana.
Okay. Then shall we move for any feedbacks?
Yes, yes, feedbacks you can put in the chat, and also we are already we got so many feedbacks, and if anyone hand raise, we can unmute them. Okay.
Those who want my number, you please give my number, okay?
Yeah, sure.
Okay, sir. We will.
Someone is asking number, so you just give my number, okay? No problem.
And the recordings will be available in our YouTube channel.
So anyone need to speak, please make it fast. Okay. They can raise their hand, we'll unmute them. Okay. About this session, and what are your responses, or what's your haha moment? Okay. Yes, we are getting good feedbacks in the chat. Thank you, Dr. Gayatri. Thank you, Dr. Vivek. Thank you, Dr. Nithi. Thank you, Dr. Srinivas. Yes. Yes, thank you, Dr. Ashok. And anyone need to speak, please raise your hand. I know you have some difficulties in network. Yes. So, yes, thank you, Dr. Ritesh. Thank you, Dr. Sri Kandapatul. Okay, Dr. Anjana, over to you. We can wind up.
So shall we wind up the session?
Yes. Thanks again, Dr. Mirdaz, for this wonderful eye-opening session. And yes, definitely.
Thank you all.
We have Dr. Rahmatullah sir is there. Doctor.
Okay.
Hello.
Thanks for your invitation. Okay. Thanks for Dr. Mohammed Mirdaz for your wonderful section. You explained all the part of the neurology is differential diagnosis, very good presentation. this is mono and poly and this diabetic neuropathy and everything is differential diagnosis is a very wonderful session. I believe this is in the day-to-day practice. The general practice is very effective. This differential diagnosis and your treatment sharing also very good. Thanks again, Dr. Mohammed Mirdaz and Ayurveda Map team, Dr. Jasur and team. Okay, thanks.
Thank you, sir, for coming.
Yes, sir.
Okay, Dr. Anjana.
So thank you all for participating in Anubhava free webinar series, and thank you, Dr. Mirdaz. Thank you so much for such a wonderful session.
Okay, good night. Good night all. Good night.
Bye.